finished. And so that helps, so we can have that kind of active learning instead of passive ones. That makes us very unique and different from all other academies where it's all about passive learning. This is an active learning. So it depends on the speaker. If he is interested to have you interrupt him at any time, that's up to him. But I will definitely encourage everybody to ask their questions after his presentation. During the presentation, that's up to the speaker. But after the presentation, I would like you to come up with your questions so we can, it's called like a preview. So that's mean we are being approved by all the doctors here, and every doctor here is agreeing about all the information that that we're presenting. If you disagree or you have a point, please don't shy. Please bring it up so we can talk and discuss, so we can learn. Well, basically, we're learning from each other here. We're all medical doctors. We're learning from each other. It's two-way learning, and that's how I feel about this conference.
Well, great. All right. Well, I think we probably got a good group here now. We're up to over 20 people. So, Dr. Cambell, if you'd like to begin, maybe give just a very brief a bio or a little bit about yourself, and begin your presentation when you're ready.
Sure. Can you all hear me okay?
Yes.
Yes. Oh, okay. And if I may interrupt, one real quick question. One thing I wanted to bring up, Dr. Halassa mentioned questions. If you have questions while Dr. Cambell's presenting, type them in the chat, and I will try to find a polite time to bring them up. But let's not interrupt Dr. Cambell during his presentation too much. But if we have to, put it in the chat, and we can bring it up as it kind of falls in. But I don't want to break his flow if he gets into a topic. But certainly, we definitely want questions and answers. So, all right, pardon me again, and Dr. Cambell, please.
Great. Thank you all. First of all, I want to thank you, Dr. Halassa, for inviting me, and your organization for inviting me to give this lecture. Briefly, I was born in Beirut, Lebanon. My dad was in the oil business with Aramco at the time. And then I was educated in Switzerland, came to the United States, did college, medical school, residency training, and all that stuff. I've got about 100 publications, and what we're going to talk about, publications in medical chapters in medical textbooks and in peer-reviewed medical journals. It's all on PubMed. What we're going to talk about today is the great masquerader of the 21st century, as stated by the World Health Organization on their website. This is an evidence-based lecture, meaning this is all medical and scientific evidence. It's not opinion. It's not, in my experience, I saw this. This is real stuff that's well supported in the medical literature. We're going to take a brief journey through molds, mycotoxins, symptoms, what they cause in the brain, neurotoxicity with the lungs. We're going to look at various mycotoxins, and then we're going to actually have case reports: autism, MS, Alzheimer, autoimmunity, the gut, mast cell activation, hormones, and then what tests to order and what treatment to give. And lastly, we're going to mention Lyme versus mycotoxins, because I think that's a great subject. And then lastly, I'm going to give you some helpful tools that you can use tomorrow morning when you start seeing patients. Briefly, I'm all these things and other things, but this is the boring part. I'm in a lot of medical journals anyway. So I would like to start with you having watched this short.
In 160 seconds, you will decide how this story ends. This is a story about us, the indoor generation. A generation that spends 90% of its life indoors. It all started the day we left nature behind. We filled our homes with lovely things and all the stuff we wanted. became places you would never want to leave. Artificial light replaced daylight, and we built our houses so that nothing could escape. We cooked and showered, breathed and played, slept and sweated. But we had closed ourselves in to a point where nothing could get out. So when the air turned bad inside, we tried fixing it with chemicals. And we put in little artificial suns everywhere to make the darkness bearable. That's when things started to happen. Hard to notice in the beginning. Some needed help to sleep, to breathe, to not itch. Many of us even started to feel sad. So we turned on happy lamps to make the sadness go away. Then, scientists discovered that the air inside our homes is up to 5 times more polluted than the air outside. And that the lack of daylight can affect children's learning and increase blood pressure. It turns out that kids' rooms often have the highest concentration of toxicants in the house. In fact, millions of homes are unhealthy to live in. They discovered that living in damp and moldy homes increases the risk of asthma by 40%. And I learned that millions of people like me suffer from asthma and allergies caused by a bad indoor environment. And so, here we are. How the story ends is up to you, because it's not written yet. If you care about the indoor generation, do something. Begin to think and live differently. Let light and fresh air into your life again. Even small changes can make a huge difference for coming generations. Learn how at theindoorgeneration.com.
So that is a brief introduction for you on molds and fungi. There's over 100,000 species of mold, but only a couple dozen give us any problems. And we've known a long time about it. It was written in the Bible. It's in the 3rd book, Leviticus chapter 14. You can check it out, and it still applies today. So climate change. We've experienced that a lot lately. Unexpected weather in most areas of the planet, hurricanes, floods, rising waters. We've heard about the Gulf Coast, etc. Disasters, damage, health hazard, mold-infested homes, schools, businesses, public buildings, etc. So cellulose, which is drywall, and other material, when it gets wet for 24 hours, it promotes mold growth. And then what happens is, as molds grow, they release spores. Molds are a plant, like a plant, and that have seeds. These seeds are spores. And these cause inflammatory and immune responses and ends up inducing chronic inflammation. So what does chronic inflammation bring on? All these diseases that we're all familiar with and deal with all the time with our patients. So this is from 1993, the New England Journal of Medicine, where they thought at that time, 30 years ago, that at any one time, 10 to 25 million workers in around 1 million commercial buildings in the US will have symptoms typical of sick building syndrome. That's what was called back then. Then it went into BRI, building related illness, and now we know it's molds and mycotoxins. So molds multiply quickly and they release mold spores. These mold spores carry mycotoxins, okay? And spores of toxigenic fungi contain the mycotoxins, and these mycotoxins are absorbed by the respiratory epithelium. Basically, your sinuses and your lungs, and then they're translocated to other sites. Look at when this was written over 30 years ago. So it's not new. Next is the diseases caused by molds or mycoses. The diseases caused by mycotoxins are mycotoxicosis. So mycosis is microbiology. Mycotoxicosis is toxicology, and we'll get to that later, but that makes a big difference in the immune response. Two important points, and that is that a mold that produces mycotoxins usually produces a whole bunch of different mycotoxins. It's not a one, this mold makes this one mycotoxin. It's a one mold, many mycotoxins. And if a mold is known to produce a mycotoxin is present in a home or workplace, then the mycotoxin it produces is present as well. Let me give you some important facts here about size. Hair is about 100 microns. Spores are 2 to 3 to 4 microns. Mycotoxins are 0.1, size of a virus. Can't see it under a light microscope. Exposure to mycotoxin is by inhalation or dermal absorption. Ingestion is hardly, it's very minimal. It's parts per billion, so it's not, it doesn't really affect us. And we'll get into that as well. So here, I'm sorry, trichothecene mycotoxins are very toxic to man, and it affects the brain, immune system, heart, lungs, intestines, etc. This is from 38 years ago. Again, this is well established in the medical literature and in science. Dr. Jarvis is at the University of Maryland, by the way. He communicated with me not too long ago. Okay, now, in mycotoxins, this is out of a publication by Dr. Jack Thrasher. So what they've said is that it's these tiny little particles, the mycotoxins, that when you get a reading from a company that comes and tests your home or your workplace for molds, and they say there's X amount of molds in that workplace, well, the mycotoxins are going to be at least 1,000 times or more than the mold spore count. Okay, that's significant. And in contrast to mycoses, mycotoxins are examples of poisoning by natural means. It's like mercury, like arsenic, like pesticides. And so it's very different from a living organism like a bacteria, a virus, a parasite, etc. But one characteristic shared by both molds and mycotoxins, and this is the only good news, is that they're not communicable from person to person. You can't catch it from another person. So what are the effects of mycotoxins? Well, immune dysregulation, they're toxic to the immune system, the brain and nervous system. They're mutagenic, teratogenic, estrogenic, and carcinogenic. And we're going to go through some of these. So they cause cancer, kidneys, esophagus, and the liver with a 10-year latency. In other words, you can have mycotoxins now and be exposed to them, et cetera, and they get in you, and then 10 years from now, you come down with cancer of the liver. Testicular cancer only in men, don't forget that. Haha. Okay, mycotoxins, how do they do this? They're potent protein synthesis inhibitors. They inhibit the synthesis of RNA and DNA. They form DNA adducts and protein adducts. They cause a lot of oxidative stress. They damage mitochondria. That causes cell apoptosis. And then mycotoxin antibodies form adducts. These adducts attach to human tissue, and that triggers and causes autoimmunity. We're going to show you some actual patient pictures before and after. What are the symptoms? Well, they're very general symptoms. And that's what makes it difficult, because this could be a lot of different diseases. And that's frustrating to a lot of doctors. Well, what is it? They have all these things. What could it be? And interestingly, pets get this too. I've had patients referred to me by veterinarians because they took their pet to the vet and the vet recognized that it was mycotoxins. Veterinarians actually have more training in it than medical doctors and osteopaths. How does this get in you? So you breathe it and these tiny little, well, the little spores get in you, and then the spores are carrying mycotoxins. So get in you versus first through the lung, the nervous system and the lungs, okay? So they enter the surfactants of the lungs, and they're carried across the alveolar cell membrane and go into the systemic circulation, and then they go everywhere. Okay, they're taken up by the alveolar macrophages and the type 1 alveolar cells. And that generates reactive oxygen species, which is inflammatory, release of pro-inflammatory cytokines, IL-6, interleukin 6 as an example, and injury to nuclear DNA. And the actual structural damage to the lungs is emphysema and granulomatous lesions and fibrotic lesions, scar tissue. So in the brain, it's different. In the brain, they get into your olfactory neurons, which are really right at the top of your sinuses, and they attach to that mucosa, and they're transported up the olfactory nerve through the cribriform plate. If you look at your anatomy book, you'll find it. It's right there, and it goes right into the hypothalamus and pituitary axis, and then affects the brain. Many mycotoxins destroy the blood-brain barrier. So that's the first place they go to. It's the overwhelming medical and scientific evidence that's the brain and nervous tissue is the first place that mycotoxins go to and that affects the body. Okay. And they attack and they bind to neural tissues such as myelin, triggering demyelination. And just to remind you briefly, myelin in the brain is made by oligodendrocytes. In the peripheral nervous system, they're made by Schwann cells. So that's a good way you can differentiate them when you order antibodies to neural tissues. You can tell, well, if it's oligodendrocytes, it's in the brain. If it's Schwann cells, it's elsewhere, etc. So, and I'll tell you where to order these things, etc. So the brain, let's take a look at the brain for just a few moments. It's the only organ that's protected by bone all around. It weighs about 3 pounds, about 2% of the body weight, but uses 20 to 30% of the calories. It gets the freshest, most oxygenated blood coming out of the heart through the carotid and vertebral arteries. 60% of the weight of the brain is fat. So be very careful about statins. I had lunch with Dr. David Perlmutter, the neurologist. You may have heard about him or watched some of his things or read his books. We were getting ready to publish something, he and I, in a journal. And the first thing he says, statins, he says as soon as he sees a patient that is on statins, the first thing he does is takes him off the statins. So brain uses, although it's only 2 to 3% of the body weight, uses 20% of the oxygen absorbed by the lungs. The hourly blood flow through the brain is 13 gallons, 20% of all the blood pumped by the heart. And there's over 400 miles of blood vessels, mostly capillaries, because each one of the 100 billion neurons we have in our brain needs oxygen and nutrients. So, and every person's thoughts, memories, emotions, actions, reactions are all in the brain. And we use the brain constantly. Now, the neurological effects of mycotoxins, a decrease in short and long-term memory, both in children as well as adults. It's related directly to autism, It can cause chronic inflammatory demyelinating polyneuropathy. There's loss of balance, facial pain. It's directly related to amyotrophic lateral sclerosis, Alzheimer's, and multiple sclerosis, as well as movement disorders such as Parkinson's disease, as well as optic neuritis. So how in the world do we do this? So here's a study, 119 patients who all worked in the same building that had a lot of mold in it, 79 females and 40 males. We had 20 controls. We obtained nerve conduction velocity studies for both motor and sensory nerves on all of these patients. And they ended up with 3 groups. The largest group, with 55 participants, mixed sensory motor polyneuropathy, and 17% it was motor neuropathy, and in over a quarter was sensory neuropathy. That is one study. And so we concluded that there was high levels of positive ANA and CNS myelin and PNS myelin autoantibodies. And so this showed us that it leads to multiple health problems involving the CNS and the immune system. And it involved initiation of inflammatory processes. So let's look at one of these. Let me go back here just a second. Yeah. So in one of these, satratoxin, that's one mycotoxins. You can test for up to 12 different mycotoxin antibodies in serum. Those are the most common and the ones that cause the most damage. So it causes, the satratoxin causes neurotoxic effects, inflammation in the brain, neurocognitive issues, fatigue, headaches, nosebleed, chest pain, fever, and of course, oxidative stress. A low dose can induce death of the olfactory sensory neurons in the olfactory epithelium. What does that mean? It means those people can no longer smell. They lose their sense of odor. I have a 30-year-old young woman who has for the last 8 years, since she was 30, been unable to smell anything. And you could put coffee beans under her nose. You can put an orange peel under her nose, nothing. Well, and then it extends the response into the brain with some mild focal encephalitis, inflammation. Here's Stachybotrys toxin, which is trichothecene. So increased capillary fragility with hemorrhage into tissues, tremors. It's a very light tremor. Headaches, we've all had headaches, but these headaches are different in how in severity, in frequency, and they're just different for these people. Seizures, sleep disturbance, incoordination, depression. I have a patient, she's a lawyer. She came to see me from another city. She was having seizures. She was put on anti-seizure medication and then she went from neurologist to neurologist, changing her medications, etc. Finally, she came to me. Well, she had mycotoxins. We treated the mycotoxins. Her seizures went away. You treat the cause, not the symptom. Demyelination, I mentioned CIDP, but it's also POTS because of the demyelination. Diarrhea, liver, intestinal permeability is common with this particular toxin. Rashes, photosensitivity, kind of a burning sensation of the skin. And as we will see with mycotoxins, a decrease in men in testosterone and increased estrogen, neither of which men want. So this is from Clinical Therapeutics from 3 years ago from Tufts University, how it shows that evidence has recently implicated exposure to mycotoxins in the pathogenesis of autism spectrum disorder. Okay, And it's mediated via different pathways that include the secretion of pro-inflammatory cytokines, especially from mast cells. So the exposure to molds and mycotoxins can affect the nervous system directly or through the immune cell activation and contribute to these neurodevelopmental disorders, such as autism spectrum disorder. Now, this is a study, and this was published a year later. 172 children with AST and 61 controls. There was a significant difference in comparing antibodies to mycotoxins between the two groups, with the ASD group showing highly elevated serum antibodies to mycotoxins. And we're actually going to see a case in just a moment. And so they implicate this other study implicated, again, mycotoxins is causing ASD. So this is something I've taught in several medical schools in the United States, in Canada, Mexico, and Oxford. Follow this. The key to solving medical problems caused by toxins is detect the cause. Second is remove the cause. Third is repair the damage. Don't treat the symptoms. Base your diagnostic testing and treatment on medical and scientific evidence, not on the opinion of so-called experts, the internet, blogs, etc. If somebody says use this, tell them, can you please give me the evidence? And if they can't give you the evidence, then that's it. So here's a case. This is an 8-year-old boy. Parents have gone to meet numerous pediatricians, pediatric neurologists. They've taken this child to naturopaths. They used various prescription medications, and you see them there on your screen. These are all commonly used. They tried various behavioral therapists and diet. They tried binders. Nothing really helped. But significantly, there was mold growing in the home. This poor boy had a very poor sleep pattern. He slept 2-3 hours at a time only. He was occasionally aggressive with biting and scratching. He had a lot of repetitive movements, which is typical for these children. Poor verbal skills. He made noises with his voice. He played alone. He never wanted to play with anyone. He had no sense of danger, and he avoided all physical contact. Here was his mycotoxin serum antibody levels. You see how many are in red, and you can see that in red there's 1, 2, 3, 4, 5, 6, 7 in red, and 1, 2, 3, 4 moderately elevated. So 11 out of 12 mycotoxins on the IgG. In the IgE, he was high in just 2. The rest were not significant. Gliotoxin and trichothecene, which we just talked about. Treatment. The first treatment is a mold-free environment. The first rule of toxicology is to get the patient away from the toxin or the toxin away from the patient. It's very simple. I put them on a gluten and dairy-free diet, organic foods only, organic juice and water from glass bottles, not from plastic bottles. I gave them spore-forming bacilli for a probiotic, and we'll get into that a little later, why. Phosphatidylserine. Then this combination per capsule, which contains omegas, CoQ10, curcumin, and resveratrol. These last two are very powerful anti-inflammatories. The only prescription medication was itraconazole, also known as Sporanox, 50 milligrams twice a day with food. So it's taken with food because it absorbed faster with food. And then magnesium. Parents noticed the improvement in all these areas at about 2 months. The first one was sleep, and then little by little, less repetitive movement, less aggressiveness. He became more social, started talking accepting affection at 6 months. He was mostly well, playing with other children, going out with his dad to play catch, all kinds of normal things like that. And here's his test after 7 months of treatment. So you can see the difference between this here and this. Oops. I'm sorry. And this here. Big difference. So let's think about another patient. Let's take it from, this was child, let's take it to the other side of life. And this is a 2016 study by Dr. Dale Bredesen, found 3 subtypes of Alzheimer's disease. And you can read there's the 3 types. And he said that the type 3, which is the cortical, could be due to exposure to mycotoxins. And another study that is not mentioned here showed that in autopsies of brain of Alzheimer's patients, 28% of them contained mycotoxins. And another study a year after this one by Dr. Bredesen in 2027 looked at why Finland has the highest dementia mortality in the whole world. And the authors of that study found housing frequently harboring molds that produce neurotoxic mycotoxins. So this is a 76-year-old gentleman. He'd been to see 3 neurologists who confirmed he had Alzheimer's after a number of tests and studies. His wife, who accompanied him, says they live in a 2-story house. Upstairs is the bedrooms, downstairs is the living areas. If he goes downstairs, he can't remember where his bedroom is. When he wakes up in the morning, he has no idea where his clothes are, pants, shirts, socks, shoes, etc. He can't leave the home because he gets lost. He doesn't recognize friends or relatives. He forgets things, and he can't drive at all. They won't let him. The medical records that I reviewed really showed only mild cortical atrophy on an MRI. So I did an MMSE, and it was abnormal. He had decreased deep tendon reflexes throughout, and also very slow pupils reacting to light. He had poor balance and unsteady gait. Otherwise, his heart, lungs, etc., were fine. And I did an Alzheimer blood screen. What is the Alzheimer blood screen? This is a test by Cyrex Laboratories. They call it a LINX array. And this LINX test looks at 7 different areas that can cause or participate in causing Alzheimer in patients. It's a great test. I use it regularly in patients that there's a suspicion of Alzheimer. But in this gentleman, it was normal, nothing positive. Here was his serum antibody levels. You can see how many he has that are positive. So I started treating him for mycotoxins. And I told his wife to find where there was mold in the house and to get rid of it, have it treated by remediation people, etc. I gave him nitric oxide BID. The one I get is called Neo 40. And it's great. I participated in a small study, in a pilot study, and it showed that it does make a difference in Alzheimer's disease. Magnesium, 1,000 milligrams, 3 times a day. Now you're going to say, wow, that's a lot of magnesium. If you know Dr. Tom Levy, he's a cardiologist, MD, and he's got a law degree as well. He's a JD as well. And he wrote a book on magnesium, which I think is great, but that's recent. But a few years ago, I wrote an article on magnesium. And basically what happens, if you take magnesium, it peaks in 2 hours in the blood. And then it starts falling off. And after about 2 to 3 hours, it's gone. So you really would need to take magnesium every 4 to 5 hours, and patients aren't going to do that. There is a form of magnesium that is a long acting, and I'll give you the details for that later on. So gave him 1,000 milligrams 3 times a day, every 8 hours. Melatonin, 3 milligrams at bedtime. Now you say that's for sleep. Yep, it helps you sleep, no question. However, it is also a neuroprotector. There are many studies that came out from the University of Texas, San Antonio, that showed how protective of the brain melatonin is. Then, as this person was an adult, itraconazole, 100 milligrams with food. And by the way, if they start not feeling well with the itraconazole, switch to Sporanox, the brand name, and they'll feel fine.
Doctor, can I interrupt for a quick moment? We have one question here about what type of magnesium do you recommend specifically? Do you use the glycinate or the threonate, or does it matter to you, or do you have a preference in that area?
Yes, and I'll get into all of that in a little bit, so you can have that kind of information. So having, was his treatment. And I also told him to use a stationary bike, 30 minutes twice a day, more if he wanted to start using puzzles, play solitaire on his computer, don't drink alcohol, and nothing in the foods, like no preservatives, no chemical additives, no artificial sweeteners, etc., and no triclosan, which, as you know, is the triclosan is that soap that comes in these bottles. So anyway, then no gluten-free, and organic foods only. And after a couple of months, I added in vitamin D3, 5,000 IUs daily. And with that, gave him phosphatidylserine as well. So to go on, and just to satisfy the question on magnesium, it's done later on, but it's dimagnesium malate that I used and that I use in my patients. It works great. After 8 months, his MMSE was almost normal. His deep tendon reflexes, pupillary reflexes were normal. His balance was much better. His gait was normal. He had no more problems with driving or going out of the house. He could remember everything. He was fine. So that's what mycotoxins can really do to you. And here was the results. You can see much improved after 8 months. Here's another study, and this is an ALS, amyotrophic lateral sclerosis. It was published a couple of years ago. And as we all know, it's the most common form of motor neuron disease in adults. It's progressive and fatal. 90% are sporadic, and 5 to 10% are due to genetic familial mutations. Now, exposure of neurons to fungal neurotoxins elicits a significant increase in glutamate production. Okay, and that is one of the hallmarks of ALS. So in this study, they said that if a fungal infection can be confirmed with mycotoxins, this could provide a straightforward treatment strategy for this fatal and incurable disease. And I can tell you that I have several patients with ALS that are doing much better, including a couple of MDs. Let's look at gliotoxin, a well-known mycotoxin, and MS, multiple sclerosis. It's one of the most frequent and severe demyelinating neurological disease in young people. And eventually they become disabled. And 11 years ago, a study from Rutgers stated We propose here that fungal toxins are the underlying cause for MS and thus offer an avenue towards an effective cure. And we know that the mycotoxin, gliotoxin, can cause demyelination leading to MS. And I have treated a number of MS patients, and they're all fine now. High levels in this study of ANA and CNS and PNS were found. So again, this is the point of view that this mycotoxins are causing these kind of problems like MS. So here's ochratoxin, another mycotoxin. Affects the brain, the kidneys, all these organs. It crosses the placenta. And the highest levels of ochratoxins are found in breast milk in lactating mothers. And mitochondrial dysfunction is one of the first signs. So you have an overall decrease in protein synthesis. And again, this can penetrate into the mitochondria, bind to proteins involved in maintenance of the membrane potential and oxidative phosphorylation. So it interferes with phosphate transport, inhibits electrons transport, and the half-life in the serum, in plasma, is 36 days. That's significant. Ochratoxin depletes zinc, IL-6 and TNF alpha secretion increases, and induces cell cycle arrest on kidney cells, as well as lung fibroblasts. And it's absorbed from the stomach and the jejunum. Albumin, which is the main protein of the body, binds with ochratoxin with unusual high affinity, 9.8%, almost all of it is albumin bound. And it's reabsorbed from practically any part of the nephron by both active transport and passive diffusion. Therefore, its elimination by glomerular filtration is negligible. So if you see ochratoxin in urine, kind of scratch your head. How the heck did it get there? So let's look at autoimmunity. Here's a study I published in the journal Autoimmune Diseases on autoimmunity and the gut. Here's a gal. This is a patient from another doctor, and this other doctor sent these pictures to me. And this gal wrote what she is under the picture. So she writes, "I look like an addict or something. Picture is scary," laughing out loud. This was a few weeks after being treated for Lyme and before I knew I had mold issues. And now she writes, I would never dream a year ago that I would be well enough to be taking, she has 3 little girls, taking by herself for a day at the beach and having the energy to do it all. You can see the difference in her face. So this is the picture on the left is from the intestinal permeability before she started treatment. The other picture on the right is 3 months later. So no more bloating with treatment. And this is, I like this picture because it's real. Patients tell me, I sometimes bloat up and I look pregnant, just like this young lady. So let's look at another case of autoimmunity. Notice the finger, the ring finger, how swollen it is from arthritis and the scaly skin of psoriasis. And obviously, this is psoriatic arthritis. Here he holds up his shirt, he shows his chest, and you can again note the finger as well as his skin. This is after 2 months treatment. He's starting to improve. And this is after 6 months treatment. Now, this gentleman had this for a long time, 12 years. He'd gone to dermatologists who gave him creams. He'd been to see a rheumatologist who gave him other medications, usual immune suppressants, etc. This is just in 6 months. His first time. I didn't want to show his face, just he's smiling. Believe me, he's smiling. So let's look at another person. Here's a lady with psoriasis. And this is her case. 63-year-old female, multiple infections, upper respiratory. And she'd been taking many different antibiotics because she'd get sick all the time from infections. She lived in a home with visible mold growth. Previous to that, in her history that was significant, is that she was a smoker, 1 pack per day for 20 years. And she quit 10 years ago. She started noticing the lesions on her legs a year previously, and she was given creams, immune suppressants, etc. Her son is a doctor, and he called me, sent me this picture and says, "Can you help my mom?" I said, "Of course." Symptoms were typical. For 3 years, she'd noted fatigue, short-term memory loss, brain fog, sleep disturbance, anxiety, the sores that take a long time to heal, recurrent respiratory infections, dry eyes, dry mouth, IBS-type symptoms, cough, heart palpitations, multiple sensitivities to food, smells, etc. So here, she moved out of the house and felt slightly better for about 2 weeks, but her symptoms persisted. She had the new home tested and was fine. She found a doctor who understood molds and mycotoxins, and he called me and spoke to me over the phone, as was encouraged by this patient's son, who was a doctor as well. So look at how positive she was. She was positive in 11 out of 12, high positive. And so treatment was started. I used the anti-inflammatory medications, as well as the itraconazole, B-complex, phosphatidylserine, etc. The diet, this part was difficult for her because she lived in a rural area, and it was difficult for her to get anything that was organic, believe it or not. After 6 months of treatment, this was her test results. She still had elevation in the high of 1, but she was much better. And here's a picture of her leg that she took with her cell phone before and after. So let's talk about mast cells, interleukin-6, a pro-inflammatory cytokine, and mycotoxins. So ochratoxins significantly increase interleukin-6, suppresses N-acetylcysteine, and increases susceptibility to rheumatoid arthritis, and it causes inflammation in the nasal mucosa. Alternaria toxin, again, IL-6, and induces damage to DNA. T2 toxin significantly elevates IL-6, increased TNF-alpha, all these inflammatory markers. Satratoxin potentiates the pro-inflammatory cytokine production of IL-6 and magnifies the innate inflammatory response. Deoxynivalenol, also known as DON, significantly increases IL-6 production from 3 to 24 hours, affects bronchial cells directly. So what does that result? Mast cell activation. This is not a lot of this is missed in a lot of patients. And I can tell you that we just completed a study with the my Mycolab and the Washington University School of Medicine in St. Louis on mast cell activation in patients. This is where the IgE antibodies to mycotoxins come, because they stimulate the mast cells. Normally, mast cells will release histamine, heparin, protease, but the IgE antibodies to mycotoxins cause more release of IL-6. And of course, these cytokines will signal the immune system to start inflammation. How do you diagnose mast cell activation? A lot of people have been, as you know, from people who suffer from mycotoxins, whether it be the others or mast cell activation or whatever, they've been to many doctors. They've had many tests, they've tried many treatments. So it's important to do a very careful and thorough history and review of systems. Be like Sherlock Holmes a little bit. And then order the IgE and IgG antibodies, and make sure you order red blood cell magnesium levels, because they can be abnormal, as well as liver function tests, and they might have thyroid issues. Of course, you can't use a urine mycotoxin test for mastocytosis. It's useless. Okay, so this is a multifunctional cytokine. Okay, and it regulates the immune response, inflammation, etc. It has a very important role in the development of autoimmune diseases. And again, most importantly, it's released by mast cells when stimulated by IgE mycotoxin antibodies. So which mycotoxins produce IL-6? 9 of the 12 most common mycotoxins. So it's much more common than people think. So here was a study done this year. 139 patients, 78 women and 61 males. Almost 3/4 had cutaneous problems. Half had GI problems. More than a third had cardiovascular issues. And a fourth had musculoskeletal, fatigue, sexual impairment. So what symptoms? Flushing and itching, low blood pressure, GI problems, irritability, headaches. We talked about that. These are different and of a different severity, different nature. Sexual impairment, neuropsychiatric problems, mainly anxiety and depression, memory loss. They have trouble concentrating. It takes them, they have to read a paragraph 2 or 3 times to understand it. And it's hard for them to learn something new. So here's a patient. This is a 28-year-old with visible mold in the home. She's very active, lots of sports, big social life, until she noticed these skin lesions starting about 3 months ago. Now she doesn't want to go out anywhere and do anything. She has seen 3 dermatologists who gave her creams and corticosteroids. And after 1 month, she gave up on that because of the side effects. What were her main symptoms? Fatigue, nausea, lots of nausea, pain. The nausea came day or night, didn't have anything to do with eating or not eating. Itching, flushing, GI complaints. Here's what it looked like. This on the left is her thighs, and on the right is her forearm and wrist. And this was her tests. Now, if you notice, her IgE antibodies are high, although she has a couple on the IgG, but it's IgE antibodies, as in Edward, that are really flaring up in this patient. So this was before, and on the right is the after treatment. And you can see on her forearm and wrist, nothing, on her neck, nothing. And this is after she moved out. She also moved down and she took treatment. But look at the IgE, they're all gone. No longer there. Before and after treatment. So you can see, wow, this is another patient. This is really makes a huge difference in these people's lives. These are all, both of these were young ladies, young women.
Dr. Andrew, are you doing any CBC differential, seeing eosinophilia, basophilia, neutrophilia?
Well, we checked into all that, but it wasn't significant. So, you know, when it's all these patients get, you know, CBC with differential, serum chemistries, urinalysis, et cetera. And most of the time, those are normal. I'll show you what comes out as abnormal. What was her treatment? She had to be out of the house while they remediated it. So she moved in with her mom. H1 and H2 blockers, diet, and megaspore biotic. Now, megaspore biotic is a probiotic that contains spore-forming bacilli, okay? And that's important because these spore-forming bacilli really improve the gut microbiome. Itraconazole, the omegas, CoQ10, curcumin, and resveratrol, vitamin D3, 5,000 IUs daily, and 1 gram of magnesium 3 times a day. Now, let me take you and explain to you a little bit about hormones, because we mentioned hormones, but in mycotoxins, it upregulates aromatase, an enzyme that is involved in the very last step of estrogen biosynthesis from androgens, testosterone, and it converts it into estrogen, and you don't want that. And certain mycotoxins are also mycoestrogens. Okay, so they bind to estrogen receptors, confusing the pituitary as to how much estrogen is actually on board. And no one wants excess estrogen, but adequate stores are necessary for proper brain function, gut function, blood sugar regulation, as well as the normal glandular requirements. T2 toxins lead to decrease of testosterone secretion in Leydig cells, decrease the testosterone biosynthesis in the Leydig cells directly. And they disrupt they interfere in estradiol, testosterone, and progesterone production, resulting in an increase in progesterone and a decrease in testosterone. And here's another one that showed that the serum testosterone concentrations were directly related in a dose-related manner to the mycotoxins. And the actual epididymal seminal vesicles were significantly reduced. They weighed a lot less. And penicillium toxin, which is a CNS depressant and a hyperglycemic agent, produces a lot of bone marrow depression, hepatotoxicity, and nephrotoxicity, inhibits testicular spermatogenesis and steroidogenesis, and increases adrenal steroidogenesis and ultimately sterility. This was done in male Wistar albino rats. Okay, so ochratoxin also impairs spermatogenesis, and it's great because it's a great biomarker because of its high affinity binding to serum albumin. So you can use it as a biomarker to treat your male patients that are having testosterone problems. Instead of just giving them more and more testosterone, check their antibodies to mycotoxins. So let's look at the thyroid, because there's a lot of patients out there who have autoimmune thyroiditis caused by mycotoxins, et cetera. Well, let's look at some of the mechanism. So this was a group of people, patients with a history of mycotoxin exposure, and then they were experiencing the usual chronic fatigue, cognitive disorders, and different kinds of hypothyroid systems, despite the fact they were taking levothyroxine. The most important factors in thyroid hormone regulation are your 3 enzymes, the diiodinase enzymes, DIO1, 2 through 3. DIO2 regulates the activities of thyroid hormone action by metabolizing the precursor molecule thyroxine, which is T4, that's secreted by the thyroid gland, and transforming it into the active molecule T3. So In this case, that in case of the mycotoxin exposure, there's a lack of T3 hormone in the peripheral tissues or the brain. And so these patients presented with normal function, thyroid function, or with required exogenous T3, and they had normal TSH, free T4, free T3, but still continued to have symptoms of hypothyroidism. So we know that oxidative stress really impacts negatively on many things, but including hormonal influences causing antioxidant imbalance and impairing the function of these 3 deiodinase enzymes. And it reduced DIO2, the conversion of T4 into T3. There's a study that was published 4 years ago. Let's look at the microbiome and intestinal permeability. So mycotoxins can cause intestinal inflammation, intestinal permeability by opening the tight junctions. I talked at a conference before COVID with Dr. Alessio Fasano here in Florida about this and mycotoxins. He was pretty interested, but then got busy in his lab with other stuff because of COVID. So what happens when you open these tight junctions is that these antigens and bacteria that usually stay in the gut or go out into the circulation and start causing inflammation. That's the invasion of these commensal and pathogenic bacteria. And that's what's called Crohn's. That's what happens with Crohn's disease. So that can be helped by, so if you have a patient with any kind of inflammatory bowel disease, check mycotoxins. That's what I do. And here's the 12 different mycotoxins. We don't have to time, and I'm sure you don't want to go over every single one of them, but these are the 12 that you can get from serum antibodies. Now, so this is serum antibodies, the most precise and accurate test for mycotoxins. That's been shown in medical literature. It's why university medical centers are using this test from my microlab to do various studies, and a couple of them are coming out pretty soon. I mentioned the one from Washington University in St. Louis. Let's talk and understand, to make sure you understand antibodies. There's 4 categories of pathogens: bacteria, viruses, pathogenic fungi, and parasites. And our immune system develops antibodies to these after an infection or an exposure. What is meant by pathogenic fungi here are some of the nuisance fungi, like those that cause athlete's foot, jock itch, etc. And then there's the ones that cause disease, which aspergillosis of the lung, etc. Those are all pretty strong disorders that usually require hospitalization. So these 4 pathogens are living organisms. They have cell walls, membranes, etc. And the antibodies means sometime in the past you had this. But toxins are not alive, don't have cell walls. They're groups of molecules. Okay, so for example, mercury or pesticides or arsenic or mycotoxins, they're not alive. They don't have cell walls. They're groups of molecules. So that's the big difference. And for pathogens, usually you take a medication, okay, and then you're done with it. If any of you have treated mercury, you know that there's no quick treatment for mercury. It takes months to get rid of mercury. 3 months, 6 months, 8 months, sometimes longer. So why? Because it's a toxin. So antibodies to toxins indicate a current immune reaction and or colonization, not sometimes in the past. And you saw the test results. Once they've been treated, the tests show up as normal. They're no longer all red, etc. So the antibody reaction fades away. And I'll be honest with you, a lot of doctors think that an antibody is an antibody is an antibody. No, it's different towards something that's alive versus something that's not. So what tests do you order? Most patients have had these common 3 tests. If they haven't, then you can certainly order it. I also order serum levels of immunoglobulins. And remember that your immunoglobulin G has 4 subclasses. It's important to know those. I order serum antibody to mycotoxins. These are elevated. I order an autoimmune panel because, as we've seen, mycotoxins can cause autoimmunity and vice versa. So in other words, if I have an autoimmune panel that's positive, I also order then a serum antibody to mycotoxins. Get a thyroid panel, red blood cell magnesium, and vitamin D3. I don't know how you see this in your practice, but in my practice, I would say 75 to 85% of my patients have low D3, either borderline low or definitively low. And you want to keep your D3 between 50 and 80. So why? As you know, there were studies done in 2020 about COVID. Why in some countries there was this many COVID and this many deaths, and another country with COVID, there were much fewer deaths. What was the difference? There was only one difference in 20 countries that they examined 2 studies. The only difference was the patients where there was less deaths had good vitamin D3 levels. What about if you suspect their nervous system is being involved because A, they have neurological complaints, fatigue, trouble concentrating, short-term memory loss, all the things we've talked about. And then you examine them and you have to do a good neurological examination and you find abnormalities like I found on that gentleman with Alzheimer. So you order the Cyrex Laboratories RA7X. This gives you the antibodies to neural tissues, myelin antibodies, oligodendrocyte antibodies, et cetera, et cetera. And if positive, this comes back to positive, then you order nerve conduction velocities in the upper and lower extremities. You want to order a brainstem auditory evoked potential. Why? Because there are studies that show mycotoxins will cause acoustic neuromas. And you want to do a visual evoked potential. Why? Because of the optic neuritis from demyelination of the optic nerve. If you want, get a brain SPECT scan because that'll tell you what parts of the brain are being less active or more active. And it gives you much more information than an MRI. Okay, so CIDP, chronic inflammatory demyelinating polyneuropathy. If the patient has neurological symptoms, has abnormal neurological exam, positive neural tissue antibodies, abnormal nerve conduction velocities, then this is CIDP. The treatment is basically you give Gamunex IV, it's intravenous gamma globulin, 0.4 grams per kilo per dose, weekly for 6 weeks. Then you give them a 2-week break and you do it again until their neurological symptoms, then their neurological examination returns to normal. And then when it returns to normal, you repeat the neural tissue antibodies, at least after 6 months. You've got to let 6 months pass. And the abnormal nerve conduction velocities, this is at 6 months. Let's talk about plant-based foods, meat, dairy products. All these can contain mycotoxins. Milk. Do you think milk contains mycotoxins? Yes, 91% of cow's milk contains 1 to 4 mycotoxins. But in general, this is in countries lacking implementation of adequate food safety policies. This occurs mainly in rural parts of certain African countries and rural China, because after they harvest it, wherever they store it is not a very good place. They don't use good storage. Okay, so here's where in the United States and other Western countries, industrialized countries, all these foods contain minute parts per billion. And what does the body do? Because that's not enough to cause any harm. You excrete it. The body excretes it. So again, here's the albumin. You can't find it in urine. And then this is from Dr. Vajdani. He asked me to include this. What is the source of mycotoxins detected in urine? And why is the detection of mycotoxins in the urine not an indication of new antigen forming between mycotoxins and human tissue antigens that play a role in the pathophysiology of autoimmune and neuroimmune diseases? And he states clearly, this is because most of the mycotoxin detected in urine originates from food. And this is why detection of mycotoxins in urine is not an indication of body burden of mycotoxins, one, and should not be used as a biomarker for exposure in water damaged homes or workplaces. Dr. Vajdani has published over 200 studies. Many doctors call him Mr. Autoimmunity because he's written books and published studies, etc., and a majority of them are on autoimmunity, or they touch on autoimmunity. And here's what I found. As you can see, the date, it was this month, but for some reason the actual date didn't come out. This was last week. And urine, this is what CDC says: use of urine, unvalidated mycotoxin tests. They say don't use it for clinical diagnostic purposes. Now let's go to Lyme disease, and we're kind of getting to the point where I'll answer all your questions. As we all know, Lyme disease, as well as mycotoxins, can cause a spectrum of neurological symptoms, a lot of different manifestations in humans, and multi-organ pathology. It varies in severity, and it's a diagnostic complexity that varies anywhere from a few months to a few years. This is an article that was published that I wrote on Lyme disease and mycotoxicosis, how to differentiate between the two. It's published in the summer of 2019, and in January of 2020, I was informed that this was one of the top 10 most read articles. And believe me, it's not because I'm a great author, it's because people want to know this. How do you tell the difference? And this article does it. And if you want the article, I'll be happy to email it to you. I give my email address at the end. So look at the situation. 3 million more than 3 million Lyme tests are ordered annually. Do you think there's 3 million patients with Lyme? No. Why? Because, you know, they're ordered just because the patient comes in with fatigue, okay, or whatever. The other part is that you can have positive Lyme tests due to cross-reactivity from other infections or other inflammatory disorders or previously treated Lyme, okay? So these patients are not being looked at carefully enough. People just order a Lyme test. And then it turns out positive, but they don't realize that it can be a cross reaction from inflammatory diseases, infectious diseases, etc. So, and then others look at co-infections, Babesia, Bartonella, or leukosis, etc., but they don't look at mycotoxins. This was published 6 years ago, I'm sorry, in Infection Diseases Clinics of North America. Mycotoxins and autoimmunity. So if, as I said before, if a patient has an autoimmune disorder, order mycotoxin antibodies. If a patient tests positive for mycotoxins, order an autoimmune panel and get it from Immunosciences Lab, test number 2011. Why Immunosciences? Because it's the most precise. I've tried all kinds of labs. You wouldn't believe how some of them are run. If a patient tests positive for Lyme disease, order a mycotoxin antibody panel. Let me tell you why. I see a lot of patients that come and they've been treated for Lyme for 6 months, year and a half, 4 or 5 years, etc., and they still feel terrible. I had this one young lady brought to me by her parents. Mom and dad brought her. She was in her early 20s. When she was 17, she went camping, got bitten by a tick, and was treated for Lyme. She kept being tired, run down, etc. So they gave her more antibiotics, multiple antibiotics for longer and longer time. She still was bad. She barely graduated from school. She was admitted to college. She had to drop out in the first semester of college because she couldn't handle it. She was tired the whole time. And she was feeling all kinds of other symptoms as well. She couldn't study, so on and so forth. Finally, mom and dad brought her to me. I ordered the mycotoxin test, the antibody panel, and she lit up. And I started treating her. 2 months later, this was the first time since she was 17 that she felt better. After that, her mom and dad called me Dr. House. I thought that was funny. Use Immunosciences Lab for Lyme because it's the most sensitive and accurate method. It's also patented. For Lyme and other tick-borne diseases, it uses a multi-peptide system of testing, which is the best way to do it, because it tells you if it's neuroborreliosis, if it's affected, if it's in the joints, if it's in other parts, et cetera, et cetera. It's a great test, and it's cheaper than some of the others too. Again, treatment. The first rule of toxicology is get the patient away from the toxin away from the patient. Simultaneously, as a second step, build back the immune system while giving an antifungals. I use itraconazole. I've never had any problems with it. People are scared. They say, oh, what about the liver, et cetera. When I first started doing this 30 years ago, I checked liver function tests every 2 weeks. They were fine. So I stretched it out to a month. It was still fine. So now I stretch it out to 2 months. It's always fine, but I do it as a precautionary method. Now let's talk about probiotics. Reading University, Dr. Simon Cutting published a study on Lactobacilli and bifidobacterium. He did this for the Food and Safety Authority of the UK, which is basically the FDA in the UK. And less than 10% of lactobacilli and bifidobacterium and probiotics are able to get to the colon. Why? They die in the stomach from the acidity. And what happens? I use the Megaspore biotic because that's the one that I've read all the studies on it. They've done studies on it, by the way, and they're great. So basic paradigm, because this is just a paradigm. It's just a general idea. They can't be around the mold spores while there's remediation going on, or if they're just going to stay there and live with the mold. It's not going to work. Make sure the diet that we've described, et cetera, they use that. 2 megaspore biotics every morning, itraconazole. Again, if they start feeling queasy with itraconazole, switch them to Sporanox, the brand name. The omega-3 CoQ10 curcumin or resveratrol is called Omega Q Plus Max, and it's from Dr. Steve Sinatra's website. I have to tell you that I know Dr. Sinatra. I know him well, and also that in 2019, Dr. Sinatra is a cardiologist in Connecticut. He and I did a study that we published as a double-blind, placebo-controlled, randomized study, and that we published. But that's not why I'm recommending it. I'm recommending because even I take it, and so does my wife. Magnesium, it's Mag SRT. It's made by an outfit called Jigsaw Health in Arizona, I think. I get these next ones from Claire Labs, and it's the vitamin D3, phosphatidylserine, 500 twice daily, melatonin at bedtime, and TheraB, which is a high B complex vitamin. Now let's look at, I get some people who don't read the medical literature. This is fluconazole. They give their patients fluconazole. Fluconazole treats yeasts. Candida is a yeast. Although it's in the family of molds, yeasts are single cell. Okay, so they're different and they respond differently. And typically, Candida is an opportunistic pathogen. 50% of us have Candida somewhere in our system, and it's kept in check by the immune system. It prevents and helps in candidiasis, has no activity against other molds, none. There's a study for it. Binders. Oh, this is a lovely one. Use this binder for this mycotoxin, that binder. There is no evidence that any of that works in humans. It's been studied in pigs, rabbits, sheep, broiler chickens, ducks, turkeys, rats, and mice. And this is in laboratories, not out in the field. This is under precise laboratory conditions with a specific amount of binder. But there isn't a single study in medical or in scientifically published peer-reviewed journals to support their use in humans. And frankly, I get about these kind of emails, about 5 every day, seven days, 365 days a year. Here's one, the latest one I got. No, this is one from about a week ago, but every day I get some of these. I've seen over 5 naturopathic doctors. They prescribed herbs, binders, and cholestyramine. These things just make me feel worse. Do you know anyone that can help me? And I hope that every one of you out there that have listened to this are going to be the person, the doctor they can turn to. Here's what binders and cholestyramine bind: estrogens, progesterones, antibiotics, high blood pressure medications, oral diabetic medication. You have to avoid them in hypothyroid. Anybody who's on any kind of hormonal treatment, diabetes, liver disease, kidney disease, etc. But I wouldn't use them in any of these. In 30 years, I've never used binders, and I've never needed to. The other part, and that's why I said this was a treatment paradigm, is that every person's immune system is unique and different, like a fingerprint. There is no one-size-fits-all treatment. It has to be individualized, okay? So for example, say you're treating a 22-year-old, 25-year-old female, weighs 110 pounds. Do you give the same treatment to that person as you do a 55-year-old male who weighs 225 pounds? Of course not. Same thing here. So individualize your treatments. Now, here's some things that can help you. I have a patient questionnaire. I'll be glad to share it with anyone who asks for it. It's a tool to help. The first 2 pages are symptoms. The patient fills it out, not you. They have to say on the left-hand side what the symptom is from 1 to 10. Say fatigue, 1 to 10, 10 being the worst. Okay. And then on the right side, they fill out when the symptoms first started. Okay. So that helps patients, helps you, because the patients kind of put it together and say, wow, I'm pretty sick, and helps you. Sorry about that. And so here is the first 2 pages. You see on the left side, the severity, and on the right side, when did you first notice the symptoms? Some people will be specific, give you a month and year. Others will just say around such and such time. But this will help guide you. Why? Because every time you see them, they need to fill this out before they see you, and you can follow them. It makes it easy. The rest of the questionnaire has 4 sections: review of systems, other potential exposures at home or at work, an occupational history, and a nutritional questionnaire as well. So lastly, I want to offer for anyone who wants, I've written a monograph about molds and mycotoxins, what they cause, how to test, how to treat, with over 140 peer-reviewed references. All you got to do is email me, and I'll be happy to send this or the questionnaire or any other, or the study on Lyme and mycotoxins. So your take-home message. If you have a patient that's been diagnosed with chronic fatigue syndrome, fibromyalgia, or has chronic Lyme, or who has seen a number of doctors without any relief, think of molds in the home and ask them, do you see any? Remember, 50% of molds are not visible. They're between walls, they're in the ducts, they're in the attic, they're in places where they're not seen. But mycotoxin antibodies may give you the answer in these chronically ill patients that have seen so many doctors. So this is how you get in touch with me. And I'm going to open up the questions here. There's a bunch. I already answered the question on magnesium. And why did I add vitamin D3 and phosphatidylserine after 2 months, not from the start? Again, every person is a little bit different. So you have to go by their symptoms, and I use my questionnaire to help me with that. Black mold. Okay. Molds produce a lot of different colors. Believe me, black mold is not the worst one, nor the best one. They're all are bad. So it's not really treating black mold. It's treating the mycotoxins they produce. Molds are the gun. Mycotoxins are the bullets. Okay. If you, IL-6, it's produced by many different types of cells. I'm an immunologist. So how do I conclude? Because if you read the medical literature about mast cell activation syndrome, you will see that. You've got to read the medical literature that's available. And then can a patient have mycotoxicosis without mold colonization? Sure. In other words, they never lived around mold, and now they move into a moldy house. Well, all of a sudden they're breathing molds and mycotoxins, etc. How do you differentiate? A, by the history, B, by the physical examination. And yes, you treat with itraconazole in either case. Let me explain to you about colonization. And Dr. Ponikow, chairman of the Department of Ear, Nose, and Throat Surgery at the Mayo Clinic, he did a study on patients with chronic sinusitis. He took 210 of them to the operating room, etc., and dug way deep inside their sinuses, frontal sinus, etc., took out whatever you could get and sent it to the lab for identification. 96% was molds. So he petitioned that it be changed from chronic sinusitis to chronic fungal sinusitis, and he gave him itraconazole, and it worked. So anyway, I think that's colonization. You can also colonize in the lungs. So if you lived for a period of time in a moldy environment and then get out of there and still feel awful, then it's colonization. But you can also feel colonization if you move into another place that has mold. Neuroquant, I never used it. I don't, that's popular with the shoemaker crowd. Shoemaker has not published anything to evidence that these things are useful, etc. And if you look at my almost 100 publications, you can easily tell that I've been doing this work for 30 years. For example, there's this HLA-DR test that's supposed to affect 25% of the US population, which would mean approximately 83 million Americans. Wow, 83 million Americans affected by HLA-DR, yet there isn't a single university publication on it. No one's looking at it. No government agency is looking at this public health problem. But it's used a lot by some people who think, wow, that must be a good test. Well, let me tell you about another disease that affects only 32 million Americans, 50 million Americans less. And everybody knows about it. There's medications for it. There's all kinds of government agencies, studies on it, etc. It's called diabetes. But supposedly HLA-DR is in 50 more million Americans, yet there is not one publication on that it has anything to do with molds or mycotoxins. Okay. And the Neuroquant is used by doctors who are no longer with Shoemaker. They're no longer, but they still carry over some of that protocol, which, believe me, does not work. I've seen so many Shoemaker patients and Shoemaker crowd patients that it keeps me very busy. So the question is, in the event that the patient is not able to tell where the mold is coming from and the blood work is showing that there is mold around, you can't. If there's mycotoxins around, how would you treat a patient who is not able to get away from? Nothing will work. And it's a huge problem, I can tell you that. I have patients who live in trailers. They don't have the economic ability to suddenly move somewhere and buy a new whatever. And the United States has no standardized mold testing, and no in homes or in buildings, and there's no standardized remediation method. So anyway, the point is that this, if you have any more, again, I am evidence-based. I look at the medical and scientific evidence. Show me that such and such tests has medical and scientific evidence, please, more than just one study, because that's nothing. I'll be happy, or even if it's just one study, I'll be happy to read it. No, Marcons is another one of these Shoemaker developed nothings. This is not Marcons does not exist. If you can show me studies that do, please send them to me. Can a person test positive for mycotoxin antibodies and not present any symptoms? Anything is possible. You can get a patient with a blood sugar of 800 and they don't have any symptoms. Or they have highly positive HIV and they have no symptoms. Anything is possible, but it's extremely rare. I've never seen it. In 30 years, I've treated more than 14,000 patients. I've never seen that. Any other questions?
If you see that all your treatment, there is no anti-inflammatory drugs involved, do you think that the antifungal itself, it could be inhibiting interleukin 6 and Th17 and Th2, which is the immunoglobulin that leads to immunoglobulin E production, and histamine, and also it inhibits interleukin 6. So that's the antifungal. It seems like it works like ivermectin. It kills the mite. At the same time, it decreases inflammations, which is mediated by interleukin 6. So it seems like antifungal, according to the publications, it does have anti-inflammatory and antifungal effect. Do you agree with me?
Yes, and if you give them your typical NSAIDs, they affect the gut microbiome in an adverse manner. So you don't want to give them those type. What you want to do is use the supplements to reduce the inflammation. You want to use what they eat to reduce the inflammation.
Yeah, I agree with your supplements, but I think the antifungal itself, it does have anti-inflammatory effect, according to many publications. So it's killing the fungus at the same time it reduces the inflammation mediated by interleukin 6.
Absolutely.
In addition to the antioxidants that you are providing, but also you do phosphatidylserine. Is that has to do with detoxing, or is just more of supplements of the brain?
Well, I think, well, first of all, itraconazole, there's several studies that show that it stopped certain kinds of cancer. So the question I would have for those authors is, was the cancer caused by mycotoxins, or was it a different, or not? Because
head south, then turn left.
Yeah, so let me explain that, because that's part of my forte. In cancer, you want to move the immune system to Th1 cytotoxic T cells to kill the cancer. And it seems like the tumor microenvironment secretes all the chemicals to favor the tumor in cancer by all the cytokines that they're produced and chemicals that tumor is producing is shifting the immune system into Th2 and Th17, which is something you don't need it for cancer. You need Th1 cytotoxic T cells. So it seems like antifungal is blocking the Th2 and Th17, which leads the immune system to move to Th1. So if you block the other side of the aisle, you are moving the immune system to Th1, and that helps to kill the cancer. So it works by immune modulation and shifting the immune system from Th1, Th17 into Th2, Th17 into Th1. Somebody is putting a voice. Can you, I don't know, is having some navigation there. Can you mute, please? Mike Beamer, can you check? So I think that's how it works. It's immune modulation. It's the same like ivermectin. It helps to kill the mites, and it has anti-inflammatory effect, which is blocking the Th17 interleukin 6. And that's why ivermectin is being used for cancer as well, because of the shifting of the immune system to Th1. So that's something we may entertain it and explain why we're using it for cancer. That's part of it. But if there's any others here who has other mechanism, please come up to the mic, because as I said, we want to have a discussion. We want to learn from each other. I mean, Dr. Andrew this is one of the best lecture ever in all my sessions and my webinars. So I congratulate you, Dr. Andrew, for this.
Very good.
This is the best of the best. And something that's been overlooked by medical community. And that's something we need to look. Nobody's looking for fungus infection seriously in the mainstream medicine, although it's the trigger of many chronic disease. And yes, it can cause direct fatigue as a cause, fatigue and all this inflammation, but also triggers any autoimmune disease that have some genetic backgrounds. Like say a patient has some genetic background of psoriasis, this will trigger it. So if you remove it, definitely it will help to subside. And also the antifungal itself, because it has anti-inflammatory effect and it blocks interleukin-6. So it's a treatment for psoriasis, for ALS. ALS is also, you have too much of Th1 and Th17. So your presentation is excellent. It's something that we need to learn about it. And your protocols of management is very unique. I like everything you present today. And I hope the audience here and the doctors here, if they have any questions, please come up to the mic. Or you have any statements, come up to the mic and let's hear from you and let's learn from you.
Okay, I want to answer this. How long is the treatment? It varies from patient to patient. Some people are exposed for a long time. Some people were exposed for a short time. Some people are also diabetic. Some people are elderly. Some people are young. The best way to find out how long is by asking the patient this question: how do you feel? They'll come to the point where they say, I feel pretty good. That's when you stop. It can take 4 months, 6 months, 8 months. It depends on the patient. Remember, it's not one size fits all. And then the question about mycostatin. That's nystatin. It's a polyene. It doesn't work against molds. It's a very, very weak treatment for anything. Obviously, if mycotoxins are 0.1 microns, HEPA filters won't do a thing. You did a mold test that tested the inside and outside air. Let me ask you, how many square feet is the inside air that was tested? And then my question or my answer to you about the outside air, how many square feet is the outside air? It's basically infinite. So you have high levels of aspergillus, et cetera. Again, aspergillus can produce a whole bunch of different mycotoxins. And what is the best way to test for unseen molds that you can smell? That's what a remediation company can do for you. Is there any natural alternatives? No, I've heard people take, say that oregano oil. Well, if that were true, there would be no mycotoxins in Italy because of all the oregano they use, et cetera. No, there is, again, look at the medical literature. So same thing with mycostatin, which is nystatin. Look at what the medical literature says. And 174 square feet, or maybe, I think that's mistaken. Anyway, again, the first rule of toxicology: get the patient away from the toxin, or the toxin away from the patient. And what a mold testing company does, they just says, yes, it does exist. No, it doesn't. The other thing is remediation people are the ones who come in and look all over because they need to remediate everything, and that's who the best place to get that remediated. In this, what I have here, the monograph, it tells you in detail about mold testing, mold remediation, et cetera. Just email me. I'll email it back to you And that'll give you an idea of what you're dealing with.
What a wonderful presentation. Thank you so much. You know, what I would say that just in summary is that this is a condition, or they're a series of conditions that are commonly misdiagnosed and mistaken for other, you know, the doctor is treating psoriasis, but hasn't discovered the root cause is mycotoxins. And I think there's a lot of medical treatment being given without the finding of the root cause, and this is one of those situations that really underlies a lot of chronic diseases, as we like to talk about in our chronic disease prevention and management sessions. So you know, he has really presented exactly a perfect presentation for this, because we want to spread the word about the how many psoriasis patients may be suffering and biologics and all these other things when they really probably maybe haven't been correctly diagnosed. And you can apply that to any of the several other chronic diseases that Dr. mentioned. So kudos to you for coming tonight. And we really appreciate it. If anybody has any questions, let's go.
Can I make a comment?
Please.
Thank you very much, Dr. Halassa. And as we say, shukran habibi.
Yes.
Yes. Thank you so much for your excellent presentation, Dr. Andrew and Dr. Zarin from Canada. Yes, I learned so much from you. I appreciate it. In regards to my mycotoxin, so I have been treating the patients with the same problems with no-sod homeopathic medicine. So I am specializing in homeopathic medicine, and I'm willing to send you my protocol and all the treatments, you know, protocols to just to view it. And if you'd like to collaborate, I'm willing to collaborate with you. So, so yes, that your protocol is wonderful. But in addition to that, I use no-sod homeopathic medicine. I don't know how familiar you are with it, but it's very effective, and the result is fabulous. So I just wanted to make a comment here. Thank you so much.
I work with doctors all over the planet. I have doctors that I work with to help them with their patients. They email me, and then we set up a Zoom. I have them in New Zealand, Australia, India, Africa, the Middle East, all over Europe. As I was raised in Europe, I speak 5 languages fluently. From all over Latin America, because I'm fluent in Spanish. And I help, you know, it takes them several of these patients till they get to the point where they're comfortable. And then that's the best way to do it. Is we all teach each other, and we all learn from each other. And the ultimate goal is to help patients.
Absolutely.
Yeah, I just want to add something here. Very important to know that fungal infection is the way that we fight it is by a polarization of immune system to Th17 and interleukin-6 and neutrophils. That's how you kill the. But it seems like when you have fungal infection, the body is overreacting and is producing too much of interleukin-6 and neutrophilia, overproduction. And that causes destruction of the tissues and cause the pathology. So using antifungal drug to kill of course the fungus, and it does help possibly inhibiting the Th17 itself to lower that overreactivity of the Th17 and interleukin-6 damaging effect. And knowing that, you know, fungal infection is Th17, Th2 dominant immune disease. So you need everything to shift to Th1 and Tregs. And all the supplements that Dr. Andrew is talking about, curcumin and zinc, they do, and quercetin, and all of those, they inhibit the Th17 to interleukin-6. In addition to that, I think we will see good results of using methylene blue. And the reason, because methylene blue does have intrinsic antifungal effect. It interferes with the mitochondria of the fungus. It kills the fungus infection. according to many publications, and I think I already post them there in the common chat room here. But also methylene blue doesn't have the interleukin-6 and Th17. And it is the best antioxidant, most the powerful antioxidant out there. It does help to reduce the ferric to ferrous, so it helps to increase the mitochondrial function and also the hemoglobin oxygen carrying capacity. So you may think about adding methylene blue in your regimen as an antifungal. I don't see any publication yet as methylene blue as a binder. In vitro, it is a binder. They use it to extract the mycotoxin from the dust. They use methylene blue, but we don't have no studies showing that methylene blue is a binder for mycotoxins. But we have studies that it works as an antifungal and has synergy to antifungal drugs that the common thing you use. Does not mean that you replace it from or replace antifungal. I will continue doing antifungal drug, but I will add methylene blue as a synergistic, and it definitely help. Maybe Dr. Andrew will try to use monotherapy or just methylene blue for his cases along with other supplements, see if it can be a replacement. But we don't have any evidence that can be a replacement for antifungal. So I will continue use the protocol of Dr. Andrew and maybe adding methylene blue as an antioxidant, antifungal, and anti-inflammatory. Maybe we can get better results. Maybe we get less the need of the antifungal. As we know, antifungal does have liver toxicity. So anything you do that helps to reduce the amount of the big pharma products, that would be great. And I agree with Dr. Andrew about statins. Statins, they are good. Yes, they're a nitroxide donor. They're antioxidant, but in short term, and it helps to lower the cholesterol. But long term, it interferes with the mitochondrial function. That's why you have problem with you have myocytes, inflammation of the muscles, because it has toxic effect on the mitochondria with long-term use. Any big pharma product out there, it's not compatible with mitochondria function. All of them with long-term, it does interfere with mitochondrial function. So they are not they don't make the study to see the compatibility of those drugs with mitochondria and redox. And most of the time, the short use of big pharma products is good, but long-term, it actually causes oxidative stress and more damage. So the work that we're doing is trying to use the big pharma in acute condition, but try to replace it as much as we can with natural products that we can do, because this definitely is the way we manage diabetic and hypertension. If you're able to reduce the amount of insulin and replace it with a healthy diet and nutraceutical and increase the sensitivity of insulin, I mean, that's management. If you're able to reduce the amount of the blood pressure drugs using the integrative approach, that is management. So we need to understand it. The big mainstream medicine, they will just write down those drugs and they start increasing it. And of course, it's being driven by big pharma to spend all this big pharma or add in more of those big pharma scripts until the body is completely toxic with big pharma. But that's different from people who are doing holistic, integrative, like Dr. Andrew. If you see his protocol, it's a mix between supplement and big pharma, and he's trying to reduce the big pharma as much as he can using other aspect or other nutraceutical products. So I'm very pleased and appreciate and happy and excited about the presentation today. And I hope everybody here, as doctors here, to contribute by asking questions or making statement. We just need you to be actively involved in the presentation. So if there's any question, please come up to the mic and ask your questions or make your statement. And we welcome you to join our team, Chronic Disease Prevention Management Fellowship, and become a member and become a clinic or practicing chronic disease prevention management across all medical specialties. So we welcome Dr. Andrew to be part of this. We welcome Dr. Praveen as well, and anybody here to join and become part of this movement. And thank you.
Thank you, Dr.
Hello?
Yeah, go ahead. Ask your questions. Yes, please.
Yes. When you start itraconazole, do you begin with a certain dose and frequency and gradually increase it, or do you start at at one dose and stay there?
I start with 100 milligrams twice a day with food. I don't change it.
Okay, and you stay that for, and how long do you maintain it?
It depends on the patient, their nutritional status, any comorbidities, how do they feel, how sick are they? And the main thing that I look at is I've given it for as short as 5 months and as long as a year. It all depends, and it depends on the question. I always ask my patients, how do you feel?
Right.
Not how are you? I
So
ask
you
them,
give it until they feel considerably better or back to baseline.
no,
Okay, thank you.
you're welcome.
Yes, please come up to the mic and ask questions, introduce yourself. I want to hear also if you're interested to join us and attend all webinars that we have every Monday. We have webinars and each doctor is presenting cutting edge, unique presentation here. And we are open for any discussion. Dr. Cheryl Ortel, do you have any questions? No?
For the excellent, thank you for the excellent discussion. And I'm in the area where Dr. Shoemaker is very prevalent. And so when I was practicing, we'd always see patients with from Dr. Shoemaker. And I think that NeuroQuant comes from the University of Virginia. And they're the ones that have all the data on whether the brain looks like it's Lyme or looks like it's mold. And he goes by, and I know he goes by what their data, what their data is. So in other words, on the test, when it comes back from there, they put it through some kind of algorithm, and it'll say whether or not the brain looks like a mold affected brain or a Lyme disease affected brain or something else.
If you get this monograph that is on here and the 140 references, there's many references on the brain, central and peripheral nervous system, how it's affected, what is the best way to diagnose it, and how to treat it. So I would encourage you to look always at the medical and scientific evidence. And I can also tell you that the effects of mycotoxins is being looked at actively by Tufts University School of Medicine, Rutgers University School of Medicine, Washington University School of Medicine, and University of Southern California, USC School of Medicine, because they're all involved in studies with mycotoxins, not molds, mycotoxins. Because again, mold is the gun, mycotoxins are the bullet.
Yeah, one of my concern is that this itraconazole are not that they're poorly absorbed, and also they don't penetrate the blood-brain barrier. So that's the reason adding methylene blue maybe will enforce any antifungal infection in the brain. Do you agree with me, Dr. Andrew, with that?
Well, I think that there are all kinds of fungal infections that on the infectious disease side, such as cryptococcosis and aspergillosis and various others that have the ability to infect humans and their tissues if the concentration of the fungi are strong enough. And and there's reports in the literature that really those happen in, let's say they happen more in places where, for instance, one is a case report on this young 21-year-old who went into a moldy silo, grain silo, and came out and had seizures and all kinds of neurological effects. So yes, you're going to have those types of cases from an acute exposure. And we all understand that when these are acute, but when it's a chronic condition, and by the way, that after 1 week, he woke up and he was fine. But what we want to look at is the things that cause chronic disorders. And I think your organization does a great job with that, because you want to find out not only how and what, but you also want to find how to treat this, which is even, so important in all this. So I think that you're going to have issues with brain, but really those are not with molds in the brain, but those are not as common as mycotoxins in the brain. And it's borne out by the medical literature and the amount of papers being written on mycotoxins and neurological issues versus mold and neurological issues. Very few on those, very many in mycotoxins.
Oops. Are you there? Dr. Andrew, are you there? Oops, he got disconnected. Dr. Andrew, are you there? Okay.
Yeah.
You got disconnected.
I'm sorry?
Dr. Andrew, you there? We don't hear you. Okay, go ahead.
You were temporarily disconnected. We can hear you now, I think.
Yeah, I have a question. It's Dr. Joseph here. And I obviously I could look this up, but I just want to, we could take care of it really quick. Ivermectin has coverage for regular fungus and molds. Is that the understanding? That it affects mold?
I've treated a lot of patients with COVID with ivermectin, but none with mold. I should say mycotoxins, because it's
We're saying methylene blue, not ivermectin. Methylene blue does have antifungal effect. And one of the drawback of using antifungal, if you have meningitis, because of the poor penetration of antifungal to the brain, you don't have much of good response in meningitis with regular antifungal. That's the reason possibly if we add methylene blue in the regimen, we may get even better results. So that's why I'm encouraging Dr. Andrew to move forward with this. And I
agree with you 100%. It needs to be explored.
I have a question with regard to itraconazole. I noticed that you are able to get the job done apparently almost all the time with itraconazole. Do you find that you find resistant organisms, or how would you know, or how would you go about determining if the organisms were responding to itraconazole? If they, I guess you'd see all the markers go down, but how if you had resistant organisms, how would that play into that?
After 14,000 patients,
right?
Okay, if you want to make spaghetti sauce, the first 10 times you make spaghetti sauce or make whatever, a pie, apple pie, it comes out pretty good. It's so. But after you've done 14,000, you can really get a feel for how to make spaghetti sauce or apple pie.
Sure.
And by the same token, I've seen, all kinds of patients, tall, short, skinny, obese, some with hypertension, cardiovascular disorders, and diabetes, and all kinds of metabolic issues, and others who are fine and athletic. After Hurricane Katrina hit New Orleans, what was that, 15 years ago? State of Louisiana sent me a bunch of its state police because they were all quitting. And the reason they were quitting is because they felt so bad. And they had, of course, the state had to spend a lot of money giving them disability.
Sure.
So they eventually sent him to me, and I'll never forget, this young man, 28 years old, who was their champion in their annual physical, they had a competition. It was all physical activity, etc. He was the champion for 3 years in a row, and he comes to me and says, I'm sick and tired of being sick and tired.
Yeah.
So then you treat them, and I used, in his case, itraconazole as well. And one day he calls me, he says, Doc, I don't need to come back to you anymore. I said, why's that? He says, I feel good. I'm going back to work. So with patients, you may not be, I don't like to treat a lab test. I like to treat a human being.
Sure.
And so in that aspect, and then there's other people, I mean, you treat them and treat them and treat them and treat them, and they still don't get better. And then you finally start asking them questions, like this little old lady, a retired 66-year-old widow, and she kept getting sick and sick and sick. And so I finally said, there must be another reason. So I spent an hour with her in a Zoom call, and it turns out that twice a week, she volunteers at her public library for 4 hours. And I asked her to take pictures of the ceiling tiles. Because I asked her, do you have mold at that public library? She says, I don't know. I said, take pictures of ceiling tiles if you see some discoloration. Well, there was a whole bunch of ceiling tiles that were discolored. So that helped me. I didn't need a lab test. I need the information from patients.
Right.
Dr. Vajdani? Could you give a starting dose and schedule for methylene blue? I assume that's IV, and what you dilute it in?
I'm not sure I understand your question. Could you type it?
For IV, for methylene blue to treat CNS or putative CNS mycotoxins, what would be your starting dose and schedule?
For
methylene blue.
And again, if you send me your email, I'll send you the monograph because it contains all this information.
Oh, okay. So the methylene blue is in there, how to treat with it?
We're adding methylene blue to his protocol. So we are just collaborating together. Where we have great results using it for COVID, but there's a lot of publications. So I will start with 10 milligram IV and then go up even 50 milligram, depending on how severe the patient is. The pharmaceutical dose, it's 0.5 milligram per kg to 2 milligram per kg. So you're using less than 50% of the lower dose of the pharmaceutical dose, and you get good results out of it. So this is something we're still in discussion. We are collaborating and see if the pharmacy, Dr. Mike Beamer, will start providing Dr. Andrew Oldest patient with methylene blue, because it does have a lot of narrative publications supporting its antifungal effect. Its binder effect, we don't have any evidence clinically, but in vitro, they are using it as binders. It does have tendency to make complex with mycotoxins. The same thing, it's being used clinically to manage prions from the virus. It makes complex and it clears the prions. But if you start 10 milligram, you can start orally. You don't need IV. You can start orally.
Oh, it can be oral.
Milligram.
Okay.
Yeah, you can do oral 10 milligram, and you can go up to 50 milligram, depending on the condition of the patient. And the reason why, and I think methylene blue would add a lot of factor here, because antifungal, they don't penetrate very well with the brain barrier. Same like ivermectin when you manage COVID-19. They don't penetrate the blood-brain barrier, so you don't have much of protection for your brain tissue when they're infected with COVID. So methylene blue does penetrate the blood-brain barrier, and actually, if you have the autopsy of the brain, patients taking a methylene blue, you'll see it blue in color.
And how often do you give it?
You can get 10 milligram daily. That's a dose that's being used by a big pharma product that they're using it for Alzheimer. They test 10 milligram with 100 milligram for Alzheimer. They find out 10 milligram daily is good, but I will go up to 50 milligram. It depends on how severe the condition is and how is the response. But you start with 10 milligram and go up. This is how, in any kind of drugs that you use, start with low and go up. see the patient tolerance response and gauge your increase in your dose. But believe me, I mean, it does have a very big effect in as in cognitive. Lots of publication helps to improve that.
Brain fog is a real common feature in these patients.
Right. So you will see the fog goes away. It also helps to increase the serotonin because it doesn't have the monoamine oxidase. So you feel the patients even have some sort of, if they are depressed, they're using it for depression as well. And
can you continue it just until the patient's better?
Yeah, the patients feel more, if they are down, they feel more kind of, it will normalize the mood because it increases serotonin. That's why you don't give methylene blue with serotonin receptor uptake inhibitor because they do have that, they can cause serotonin syndrome if you use high dose of methylene blue and CSR. But I think this is something you may consider. If you add light therapy along with it, you put them in the bed of red light and infrared, I think that will help to enhance the efficacy of antifungal of the methylene blue. But there's lots of publication. I just post them there. Again, use the same protocol of Dr. Andrew, and we're going to add methylene blue, and Dr. Andrew will come back with his, and all of you here, with your reports and see if we can, speed the process of recovery, adding. So this is the reason why. The other thing, Dr. Joseph James here, he is also part of the chronic disease prevention management, and he is loading the methylene blue in the platelets nanoparticle, and then the intranasal or IV, which helps the delivery of the drugs into the pathology. The platelets nanoparticles has receptors that has tendency to attract to the fungal, bacteria, viral, inflammasomes. So that's the reason we use nanomedicine technology, and you can do it clinically. And I train doctors to do that. I provide them with the equipment, the training, so they can use nanoparticle of platelets. There's a companies doing it, but they are adding PLGA to make it more stable. We don't need it because in clinical, you just have to make it and inject it to the body or intranasal it. And I think Dr. James also is adding other peptides, which help to modulate the immune system. In case of fungal infections, it depends. If there is demyelinations, then he needs to really consider blocking interleukin-6 signaling. And I think erythropoietins, peptides, it does polarize the immune system into Th2. So I may use thymosin alpha in those cases of antifungal, especially if you have too much of interleukin-6, you want to move things into Th1. But it doesn't have the Th17, the erythropoietin peptides, along with low-dose naltrexones. All of this may help to for demyelinations of the neurons. But along with what Dr. Andrew is recommending, adding phosphatidylserine and all those and B complex and things that he's adding, I think it add value to but I will add peptides, and I think something that may Dr. Andrew will agree with me about adding peptide as immune modulation to help to block the Th17 overactivities, which is, I think, most of the autoimmune disease, whether it's Th1 or Th2 dominant, they have a portion of Th17. That's a common thing between them. And blocking that Th17 does help both aisle, whether it's Th1 dominant or Th2 dominant autoimmune diseases or neurological diseases. But the protocol of Dr. Andrew, it's great. It's a good base. But I'm looking for doctors to add to what we have and possibly to increase the efficacy and the outcome. So, but Dr. James, do you want to come up to the mic and add something?
And no problem. Just one last thing. No problem co-administering methylene blue and itraconazole.
Yes, there's synergistic effect between both of them. I'll send you publications about them.
Would you give one at a different time of day than the other, or would you give them together?
It doesn't really much difference. And the methylene blue is very absorbable. 99% will be absorbed. it does not interfere with the mechanism of antifungal drug.
Both of those drugs you give twice daily, though. I want to clarify that methylene blue oral, it only has a half-life of 5.5 hours. So you would want to do that in 2 doses, 1 in the morning, 1 at night. And I believe itraconazole is the same way. But just to clarify that.
And no problem giving methylene blue with food. You give itraconazole with food, so you could give them together with food.
Yes. Yeah. Methylene blue is very absorbent, super water soluble, as is evidenced if you ever spill it.
Yeah. Yeah. Yeah, I was going to say just one of the strategies I do is that I'll make a nasal spray. Say, for example, there's a lot of rain fog.
Mike, we lost him. Dr. Joseph, we lost you.
Yeah. Sorry, can you hear me now?
Can't hear you.
Yeah.
Sporadic. It
sounds
like your internet connection, maybe.
Connection is a little bit. It should come back here in a second.
Gentlemen, do you have any more questions for me?
Yeah.
Yeah, let's we have gone on probably over our time. Let's see, what are we at? We're at almost 10 o'clock. Yeah, if we have any last questions for Doctor, let's let him have those. And if not, we can continue our conversation if we like, but we want to be respectful of Dr. Campbell's time. Yeah. All right. Anyway.
Okay. So,
Well, very good. Dr. Campbell, what a wonderful presentation. Thank you so much. Obviously, the word needs to be spread wide and far about your achievements and work and your fantastic ability to present these important facts. So thank you for that.
Yeah. I mean, there's a lot of potential work, and I can tell you that after lecturing at Oxford, they're getting interested, but they were sidetracked. Everybody was sidetracked with COVID. But they were very interested when I was lecturing over there.
Yeah, you've peeled away another layer of the onion of the root cause of disease, and for some people it will be, and that's
and you will have a lot of patients now with post-COVID-19 because their immune is being disturbed. Chef2 Th17 overactive. They are susceptible to fungal infections. That's what's happened in India. The black molds, and they use methylene blue for that, by the way. But of course, I will be encouraging giving antifungal. But we will have huge amount of increase in the number of fungal infection with post-COVID-19.